Welcome to this high-yield explainer. If you are prepping for your advanced pathophysiology or PMHNP exams, you are in the exact right place. We are going to trace the literal timeline of a cell under stress today. I'm incredibly excited to take you on this cellular journey, breaking down exactly how normal physiology morphs into pathophysiology step by step.
So let's dive right into the big question we need to answer. How exactly does a perfectly healthy cell cross the point of no return? How does it tip over into irreversible injury and death? Understanding this exact threshold, that precise tipping point, is the absolute key to mastering disease mechanisms for both your exams and your future clinical practice.
Here's our game plan today. 1. Cellular homeostasis and immunity. 2. Cellular adaptation mechanisms. 3. Pathways of cellular injury. 4. Bacterial pathogens and pathophysiology. And finally, 5. Cell death, necrosis versus apoptosis.
Section 1. Cellular homeostasis and immunity.
Okay, when pathogens thirst crash the party, your innate complement system rapidly kicks in. It fires off 3 sequential steps to assist with early inflammation. Step 1 is opsonization, basically tagging the pathogens so they're easily recognized. Step 2 is cell lysis, which involves forming the membrane attack complex, or MAC, to literally poke holes right in the pathogen. And step 3 is chemotaxis, acting like a chemical homing beacon to draw even more immune cells to the site of infection.
Now notice the stark contrast between these two arms of your immune system. Your innate immunity is your rapid, nonspecific first responder. It relies heavily on neutrophils, but it has absolutely zero memory. On the flip side, adaptive immunity takes a bit longer to spin up, but it is highly targeted. It's driven by plasma B cells that create very specific antibodies. And crucially, it remembers that exact pathogen for next time. It's like a sniper versus a shotgun.
You'll definitely want to burn this into your brain for your board exams. Toll-like receptors, or TLRs, are the crucial bridge between that innate and adaptive immunity. Why? Because they're pattern recognition receptors that detect PAMPs, those are molecules found on pathogens, and DAMPs, which are danger signals released from your own injured cells. The second they detect these, they trigger the cytokine release that kicks your whole immune response into high gear.
Section 2. Cellular adaptation mechanisms.
Now, let's map out this progression. You start out with normal, simple cuboidal cells, but introduce some stress and they might shrink, that's atrophy, or they might enlarge, which is hypertrophy. They can even multiply, called hyperplasia, or change their type entirely, which is metaplasia. But what you really have to watch out for is dysplasia. This is deranged, chaotic cellular growth, where cells completely change size, shape, and organization. While it's not a true adaptation, recognizing this atypical hyperplasia is incredibly critical.
Let's zero in on hypertrophy for a second. Pathologic hypertrophy, like a dramatically thickened left ventricle from a patient with chronic hypertension, is basically a compensatory response to mechanical overload. Initially, synthesizing more proteins allows the heart to do more work. It's trying to keep up. But prolonged pathologic hypertrophy, that eventually leads to interstitial fibrosis, cell death, contractile dysfunction, and ultimately, total heart failure.
Unlike hypertrophy, which just increases cell size, hyperplasia increases the actual number of cells. It requires the cells to undergo mitosis. This is the exact literal mechanism behind benign prostatic hyperplasia, or BPH. The cell number increases so dramatically in response to age-related hormonal imbalances that the enlarged prostate actually protrudes right into the lumen of the bladder.
All right, this next one is a classic exam scenario. Metaplasia is the reversible replacement of one mature cell type by another. Think of your classic chronic cigarette smoker. The chronic irritation from all that smoke causes normal ciliated columnar epithelial cells to reversibly change into stratified squamous epithelial cells. Sure, they might withstand the harsh smoke a bit better, but they totally lose their cilia and protective mucus. It's a massive trade-off that seriously compromises airway defense.
Section 3. Pathways of cellular injury.
Think of this progression as your mental roadmap. Notice that an adapted cell is neither normal nor injured. It's in a gray area. But if the stress persists or gets too severe, the cell crosses over into injury. Initially, this injury might be reversible. If you remove the stress, the cell can actually recover. But there is a very real point of no return. Once we cross that line, it's irreversible injury, and that inevitably leads to cell death. Let's break down the single most common cause of cellular injury: hypoxia due to ischemia. You need to memorize this exact sequence. First, oxygen drops. Without oxygen, the mitochondria's ATP production just completely tanks. Without ATP, the energy-dependent sodium-potassium pump on the cell membrane completely fails. This allows sodium and calcium to absolutely flood into the cell. And since water always follows sodium, you get acute, massive cellular swelling.
Following that exact cascade, the thing you absolutely must focus on is calcium. An influx of increased cytosolic calcium is the lethal trigger here. It activates ATPase to further deplete your remaining ATP, phospholipases to destroy the cell membrane, and proteases and endonucleases to wreck the nucleus. This is the precise mechanism of how reversible swelling turns into completely irreversible structural destruction.
Now remember that ischemic injury doesn't just happen in a vacuum. There's a deeply intimate relationship between hypoxia and inflammation across all your organ systems. Dead or dying cells release those DAMPs we talked about earlier, those danger signals that immediately promote widespread tissue inflammation. Hypoxia causes inflammation, and inflammatory conditions can ultimately circle back and lead to hypoxia. It's a vicious cycle.
Section 4. Bacterial pathogens and pathophysiology.
For your microbiology questions, you should always contrast these two gram-positive cocci. Staphylococcus aureus is catalase positive and coagulase positive. That coagulase enzyme causes plasma to clot, making it highly virulent. Think toxic shock syndrome or severe nasty wound infections. On the other hand, Staphylococcus epidermidis is catalase positive but coagulase negative. It definitely has lower virulence, but it's notorious for producing urease and forming thick adherent biofilms on prosthetic devices and IV catheters, especially in immunocompromised patients.
You also really need to know about the M protein. Streptococcus pyogenes, the culprit behind strep throat, uses this as a major virulence factor. It's an antiphagocytic protein that extends right out of the bacterial cell wall and actively blocks your macrophages from engulfing it. It is literally fighting off your innate immune response hand to hand.
Section 5. Cell death. Necrosis versus apoptosis.
Take a mental screenshot of this breakdown. You absolutely must know the difference here. Necrosis is messy. The cell enlarges and swells, the plasma membrane is violently disrupted, the contents leak out everywhere, and it immediately triggers adjacent inflammation. It is invariably pathologic. Apoptosis, however, is neat and tidy. The cell shrinks, the membrane remains perfectly intact, cellular contents are safely packaged into apoptotic bodies, and there is zero surrounding inflammation. It's very often just a normal physiologic process of cleaning up unwanted cells.
Depending on the organ and the cause, necrosis looks totally different under a microscope. You have coagulative necrosis, which is typical of ischemic injury in the heart. Liquefactive necrosis happens in the brain because brain tissue is so rich in hydrolytic enzymes. Caseous necrosis, looking kind of like clumped cheese, is the classic hallmark for pulmonary tuberculosis. And fat necrosis occurs in the breast or pancreas, where lipases inappropriately break down triglycerides.
Unlike messy necrosis, apoptosis is a highly regulated suicide program. You've got the intrinsic mitochondrial pathway triggered by internal stress like DNA damage, and the extrinsic death receptor pathway triggered by external signals. But here's the key. Both pathways converge to activate special enzymes called caspases. These caspases act as the executioners, neatly breaking down the cell's cytoskeleton and DNA from the inside out, prepping it for phagocytes to sweep it away without leaving a single trace.
We know autophagy is a survival mechanism, where a cell basically eats its own contents to survive stress. But as you study your clinical vignettes tonight, I want you to ask yourself this final question. If a stressed cell uses autophagy, eating its own organelles to survive starvation, at what exact molecular moment does this cellular cannibalism cross the line into programmed death? Finding that exact tipping point is the ultimate key to understanding advanced pathophysiology.